Welcome, everybody. We're very excited to present the first webinar for our Parkinson's Support Center of Northern Nevada. We are really excited you were able to join us and wanted to give a brief history of the Parkinson's Support Center of Northern Nevada. We are a brand new nonprofit, just started June 21, just this past June. And at this point, we are actually the only nonprofit organization in Northern Nevada supporting people with Parkinson's disease. The APDA closed their Information and Resource Center last fall, so we are it. We are a dedicated, hardworking board of volunteers. We have no paid staff, so all our programs are volunteer run. We're a 100% giving board, and we're just very excited to be able to provide services. Our mission is to improve the quality of life for those living with Parkinson's disease, their families, and care partners in Northern Nevada. And our goal is to connect people to the information, support services, programs, and activities they need to enhance wellness and to live an active and engaged life with Parkinson's disease. An introduction to our webinar structure. First, if you get disconnected, don't worry, go back to your email, click on your link, and sign in again. Also, this webinar is being recorded, and it will be on our website in the near future. Dr. Niemann will be speaking for approximately 40 minutes, and then we'll take questions. We've had a couple questions submitted ahead of time, but if you have a question, feel free to hover over the bottom of your screen, see the Q&A button, click on that, and write in your question at any time. We will address the questions during the Q&A session for the last 15-20 minutes. We'll try to get to everybody's question during that Q&A period if possible. Now I'd like to introduce Dr. Niemann. Nicki Niemann is a neurologist at the Muhammad Ali Parkinson Center and assistant professor of neurology at the Barrow Neurological Institute. He is board certified in neurology by the American Board of Psychiatry and Neurology, and he has specialization in movement disorder. Dr. Niemann's expertise includes the diagnosis and management of Parkinson's disease and other movement disorders. He is a member of the American Academy of Neurology and the International Parkinson and Movement Disorder Society. Dr. Niemann's research interests include clinical trials, translational research in Parkinson's disease and other movement disorders, the genetics of Parkinson's disease, and novel applications of botulinum toxin. Please welcome Dr. Niemann.
All right, thank you very much for that kind introduction, and thank you for everything that you do and for everything you do for people with Parkinson's in the state of Nevada. I think I'm going to go ahead and see if I can share my screen. It worked great just a minute ago. And do you see the screen here? Are you seeing my screen here?
Yes, you're good.
Okay, all right. Okay. All right, and I trust that you also see the screen here. So the intent of this talk is to go into a bit of details about the newer treatment options that are available for Parkinson's disease. And to do that, I'm going to try and also talk a little bit about what's already on the market and some of the problems that are associated with the currently available treatments for Parkinson's disease. Before I do that, though, I'd like to start with a message of hope and impress upon you these tremendous advances in the field of Parkinson's disease research and therapeutics, which has happened over the past 205 years. 205 years ago in 1817 was, of course, the first time that someone adequately and comprehensively described the disease that would later come to be known as Parkinson's disease. And that was the essay published by James Parkinson in 1817. But if you look at this graph starting up here in 1817 and ending in 2018, you'll notice that the first 150 years takes up not even a quarter of the graph. And you will notice that it wasn't even until the 60s that the role of dopamine was understood. And it wasn't until the 60s and 70s before we had the first effective treatment for Parkinson's disease, which of course is carbidopa-levodopa. Not even 25 years after not even 30 to 35 years after this medication became available, did we then get deep brain stimulation surgery, which has been a highly effective and very well used and available treatment option for people who have generally a more advanced Parkinson's disease or who have certain complications to the established treatments. If we look on the genetic landscape of Parkinson's disease, it wasn't until 25 years ago that we first discovered the first gene causing Parkinson's disease, which was the gene encoding alpha-synuclein. And in short order, about 15 years later, we had the first immunotrial, or the first trial of an immunotherapy for Parkinson's disease. And since then, numerous other genes have become known to cause Parkinson's disease, and much more detail has come to light about what really happens in someone who has or develops Parkinson's disease. And so that's leading to more specific trials targeting specific disease mechanism. And one of the most recent advances is the use of focused ultrasound to provide a very effective treatment for tremor and potentially other slowness and stiffness in Parkinson's disease. And we'll talk about that as well toward the end of the talk, actually. I'm not going to waste all your time spending a lot of time on motor symptoms and non-motor symptoms in Parkinson's disease, because I think most people are familiar with what these problems might look like. But I'm showing you on this slide and the next two slides some of the more common motor symptoms and non-motor symptoms that can be seen in Parkinson's disease. It doesn't mean that because these symptoms are listed here that everyone with Parkinson's disease has each of these symptoms, just that these are potential symptoms that may or may not be experienced by a person with Parkinson's. And so when we are talking about treatment of Parkinson's disease, these are the symptoms that we want to address. When it comes to the cardinal features of Parkinson's, all the established medications treat those types of symptoms, but and these are other examples of motor symptoms that one might see, such as reduced small size of handwriting, reduced facial expression, swallowing problems, drooling, etc. But what we don't have good and established treatments for in many cases are the non-motor symptoms, such as the autonomic issues, the mood issues, problems with memory and thinking, pain, loss of sense of smell, etc. And these are, at least some of these issues are addressed by the newer medications on the market. On this slide, I've added a couple of pictures of basically famous people, and you may know some of who they are, you may know all of them. You may also know that all of these people on this slide have been diagnosed or had been diagnosed with Parkinson's disease. And most are men, some are women, some are older, some are younger, and they don't look anything alike. And the point is that neither does their Parkinson's. And most people who have Parkinson's disease have a certain story or there's a certain theme to the symptoms, but everyone has a different experience. Everyone has a different symptom, and some people have more tremors. Some people don't have as much tremors. Some progress exceedingly slow, and some progress at a faster pace. Some have cognitive issues, and some never have cognitive issues. Some have very severe blood pressure fluctuations or bladder issues, and some have a great medication response, and some don't. The point here is that we, as physicians, the important thing is to figure out what is the issue so that it can be properly treated. But more than that is also to figure out what is the issue for the person. I've met many patients who have considerable, let's say, resting tremor, and it just doesn't interfere with their lifestyle. And then I've met other people where the tremor is a constant reminder, it's a constant nuisance, it's distracting, and it may interfere with their hobbies, their lifestyle, their work. And in that case, it can be a huge issue. And one size does not fit all, and that's certainly the case when it comes to Parkinson's. So before we look to the present and before we look forward, I think it's important to look back and just get a lay of the land and get an understanding of the landscape of available treatment options or of established available treatment options. Levodopa is the gold standard. Levodopa, I think, will always play a central role in treatment of Parkinson's disease because, as most will know, in Parkinson's disease, there's a lack of dopamine, and levodopa is exactly the molecule that the brain makes before it then converts it to dopamine. So when we take levodopa by mouth, it goes to the brain, becomes dopamine, and it helps with slowness and stiffness and tremor. And the ultimate outcome of that is improved quality of life and longer lifespan. The so-called dopamine agonists, and I've listed the names here, I think of them as synthetic dopamine. They kind of do the same, but they're not quite the same medication. And they have certain advantages and disadvantages. And one advantage for sure is that they last longer than levodopa does. Then we have a range of other medications. We have extenders such as entacapone and selegiline, and there are more than those that can make levodopa stick around longer. We have, I think, medications like amantadine and trihexyphenidyl, which can be used for tremor in particular. Amantadine also has a role for dyskinesia, which we'll talk about in a few slides. And then you might be puzzled that deep brain stimulation surgery is here. But the fact of the matter is that even though deep brain stimulation surgery has still has been in the market for more than 25 years, it is still one of the established treatments. And the core of what deep brain stimulation is has not changed much. So what are the issues with the established medications? Well, one issue which pertains primarily to levodopa, but also to some of the other medications, is the issue of motor fluctuations and dyskinesias. I'm not going to read these definitions to you, but I'll show them on the next slide by way of a figure or a picture. But before we do that, I just want to mention two things, and most people may know this, but I'm going to define it real quick. Neurologists often use the terms off state and on state when it comes to the medication response. So someone who's never been treated for Parkinson's or someone who hasn't had a dose of medication in a while will be in the off state. So they will have more Parkinson's symptoms, more tremor, more slowness, more walking issues. And when they take their levodopa, hopefully they're taking it at an adequate dose. And as the medication kicks in, there's going to be less tremor, less slowness, less stiffness, and a more natural condition and a more normal condition. And that's the on state. So if we look at this picture, and if this uses levodopa as the example, and these are blood levels of levodopa, and at the bottom we have early, moderate, and advanced stage of Parkinson's disease. In the beginning, first 5, 6, 7, 8 years for most people, you may take the carbidopa-levodopa at 8 and at 1 and at 6, and the levels go up, they go down, up and down throughout the day, but you're always in the green zone. So the medication seems to always work. It doesn't cause side effects. It doesn't wear off. But as time goes on, the green zone gets smaller. That means that the peak dose that before did not cause any issues now leads to excess movements or dyskinesias. So these may be twisty, back and forth, sometimes dance-like movements. People often ask for examples of what dyskinesias might look like, and I often point to someone like, let's say, Michael J. Fox, which many people will have seen on TV exhibit dyskinesias. When the medication dose drops and we get down to the lowest level, before that didn't cause any issues, but now it leads to a very tangible and very apparent off state where it might be difficult to arise from the chair. There might be more tremor. And then you take the dose again and turn on, so to speak. And then we have that fluctuation throughout the day. So when we talk about off state, followed by on state, followed by off state. We're talking about motor fluctuations. And I think it's helpful if for someone with Parkinson's to be somewhat familiar with these terms, because it does help communicate more effectively with your physician. And that's going to make it easier for the physician to help you with the problems that bother you the most. Other issues with these medications are listed here. Dopamine agonist withdrawal syndrome is a side effect that pertains to the dopamine agonist, like ropinirole. And I think of it as a type of withdrawal syndrome, a type of basically an addiction problem where you stop the medication and the brain craves it. And so the brain creates certain psychiatric and physical symptoms like anxiety, depression, pain, spasms, and other problems. The only treatment for this particular problem is to go back on the actual dopamine agonist. Impulse control disorders are also more common with this so-called dopamine agonist and refer to things like compulsive shopping, gambling, drinking, and eating. Can be very mild. In most cases it is, but it can also be quite severe. Most medications, unfortunately, can promote or can worsen excessive daytime sleepiness and drowsiness and lack of energy. Some can cause or worsen hallucinations, in particular trihexyphenidyl, amantadine to some extent, and the dopamine agonist as well, and perhaps a little bit less so levodopa. The only medication that really causes cognitive impairment or has the risk of causing cognitive impairment is trihexyphenidyl, and we use that exceedingly rarely for precisely that reason. Most can cause constipation. Some can cause increased fall risk. Most will actually reduce the fall risk by improving the Parkinsonian symptoms. But if you have someone who they have low blood pressure because of their medications, or they have severe dyskinesias because of their medications, this might actually lead to an increased fall risk. And when it comes to the surgical treatments, well, we have the risk of surgery itself from those treatments because they are highly invasive. And as I alluded to before, unfortunately, these established therapies mostly do not address non-motor symptoms. So what are the newer treatments? I've tried to list them in this table, depending on what their main function is. So do they reduce off time, dyskinesia? Is it an infusional therapy? Do they treat psychosis or something else? So if we start toward the left side, newer medications to reduce off time. You may be surprised that I included good old carbidopa levodopa here. And the reason why I did that is because carbidopa levodopa is a medication that is under continual development and is constantly being reformulated to overcome some of the issues that the medication has. So Rytary is the most recently approved long-acting version of carbidopa levodopa, and I'm including it here because I would say majority of the people that I meet have never heard of this medication, and I think it has a huge role in the treatment of Parkinson's. And if it wasn't so darn expensive, I think I would use this as my first-line medication for almost everyone. So what is it? Well, it's a capsule that comes in 4 different strengths, and that capsule contains fast release and slow release carbidopa levodopa. It is very useful to reduce off time, and it may also allow someone to cut down their number of doses they take in a day. So from 5 to 4 or from 4 to 3 or something along those lines. It may also be helpful in some cases when the regular carbidopa levodopa is poorly tolerated. And that's not because it's a different medication, it's still carbidopa and levodopa, but it is a medication that is released more slowly in a more gradual and gentle fashion. And therefore, some people tolerate this medication better. This medication, unfortunately, has obstacles and has downsides. Number one, I think, is that it's very expensive. It requires authorization by insurance, and oftentimes insurance will mandate that this person must try and fail medication X, Y, and Z, and then we can talk about getting this medication approved. Another obstacle to using this medication is that the conversion from regular carbidopa to levodopa is not one-to-one. You might think that if you're taking, let's say, 2 tablets of the regular carbidopa levodopa, that you're just going to take a similar amount, 200 milligrams of levodopa in the form of Rytary. But that's not the case. Usually, to get the same effect from Rytary, you need to double or even triple the dose of levodopa in Rytary relative to regular carbidopa levodopa. So I'll give you an example down here. Someone is taking 25-100 of carbidopa levodopa, 2 tablets 5 times daily. So that's 1,000 milligrams. If I were to convert this person, depending on the situation, I might give them 245 Rytary, 2 capsules 4 times a day. So that's an equivalent of almost 2,000 milligrams, or double the dose. And this may actually prove to be a too conservative conversion. So always try and impress upon people that some tweaking of the dose is definitely required. Otherwise, people may just switch, feel like this is not working, it's not kicking in, and then abandon Rytary prematurely. But I do think it works really, really well. Another way of addressing off time without switching to a long-acting levodopa is simply to make the levodopa that you take stick around longer. So Ongentys and Xadago are new once-a-day medications that prolongs on time by preventing the breakdown of levodopa. Ongentys is similar to entacapone, and Xadago is similar to rasagiline and selegiline. A difference, though, is that whereas Ongentys is once a day, entacapone has to be given with every dose of levodopa because it's short-acting. Another interesting medication that's come on the market recently is the medication Nourians, which has a novel mechanism. It blocks the so-called adenosine A2A receptor, and it doesn't make levodopa stick around longer. It just makes levodopa work more effectively. All of these medications have a modest effect on off time, reducing it by at least an hour a day. But since all medications essentially work on levodopa, they can potentiate or cause the same type of side effects as levodopa can. So dyskinesias, low blood pressure, feeling tired, or whatever the case may be. Another way of combating off time is to use rescue medications. And so when would a rescue medication be relevant? Perhaps if someone has an unexpected off time, they may be going to the grocery store, and then the levodopa wears off and they have trouble walking. And then taking a rescue would be something that would be very convenient, especially if the next dose of levodopa is not for another hour or 2 hours or even 3 hours. Kinmobi was just approved in 2020, and it's really only been widely available in the US in the past, I would say, 6 to 12 months. It is a small film, kind of like a chewing gum, that you place under the tongue, as shown in the picture. It then dissolves, and it is absorbed through the mucous membrane. The main advantage to this medication is that it's very easy to use and kicks in pretty darn quickly. But the downside is that the first dose has to be taken in the doctor's office to monitor for the main side effect, which is low blood pressure. It can also cause nausea, and it can cause some irritation of the mucosa in the mouth. Those are other drawbacks. And an alternative to Kinmobi is Inbrija, which is seen down here in this picture. It's basically like an asthma inhaler that contains levodopa. So the way you take it is that you twist this device apart, put in a capsule, compress the device again, and then take an inhalation, and then repeat once more, because you have to take 2 capsules to get a full dose. The main advantage here is that it is good old levodopa. It's the medication that you're most likely already taking. And the downside is that if you're off, and if there's more tremor, and if there's more slowness and stiffness, it may require a little too much hand dexterity to be able to administer the medication. And if someone is diagnosed with asthma or COPD, we just can't use these medications. They're contraindicated. Both of these drugs, by the way, have been tested here at our site in Phoenix. Moving on to new treatments for dyskinesia. I'm sure you all know amantadine, and amantadine is one of the established medications, and I still think Gocovri and Osmolex deserve a mention in this talk since they were recently on the market, recently approved, and I think work better than regular amantadine. The way you take Gocovri is once a day at bedtime, and the way you take Osmolex is once a day in the morning. Gocovri, I find, is particularly effective because when you take it at night, it is slowly released as you sleep, and by the time it's morning, the drug will have reached its highest level and its highest effectiveness and will stay very steady throughout the day. It'll not only suppress dyskinesia, but it has been labeled for another indication, which is reduction of off time. So I think that there's that added benefit of taking the long-acting version of amantadine. Unfortunately, Gocovri is very expensive, 20 times more expensive than regular amantadine. And Osmolex somewhat remedies this situation by only being 3 to 4 times as expensive as regular amantadine, but still quite expensive. I added out in the box here that when someone is experiencing dyskinesia, I don't think the first choice necessarily would be adding on amantadine or Gocovri even. First, you would try and work with what the person is already taking. So let's say a person is taking 3 tablets 3 times a day. You might want to try and lower the dose and spread it out more evenly throughout the day. That might look something like 2 tablets 4 times a day or something similar. I like to keep things simple, and if we can manage things without adding on more medications that could have their own potential problems and side effects, then I think we're overall much better off. There are 2 exciting infusion therapies, or 3 rather, that either are on the market or may soon be on the market. And these have the capability of potentially both reducing off time and dyskinesia, and may have a huge role in as an alternative to deep brain stimulation surgery. Duopa, again, is not necessarily brand new. It's been approved since 2015, but again, I find that most people I see have just never heard of this medication, and I do think it works really, really well. But what is it really? Duopa is carbidopa-levodopa, and it has to be administered through a feeding tube. And so surgery is involved, and that is the main drawback to this treatment. And that's the main thing that people are not excited about. But the advantage here is that we bypass the stomach, and the feeding tube goes into the small intestine. Some people with Parkinson's may take their medication at 11 o'clock in the morning, and then it doesn't kick in until it's 12, 12:30, 1 o'clock, or 2 o'clock. And what happens in many cases is that the medication sits around in the stomach for a long time, an hour or 2 hours. It's then released to the small intestine where it can be absorbed and start working. So by bypassing the stomach itself, the medication is delivered directly to where it needs to go, to the small intestine. And typically, this device is worn on a fanny pack or around the chest or around the shoulder, on the hip, started in the morning, and it runs 16 hours throughout the day. It can be used 24 hours a day if desired, but that would be considered off-label for this medication. This medication is very effective in cutting down off time, increasing on time, and reducing dyskinesia. A newer alternative to Duopa is subcutaneous infusion. And the big highlight here is that subcutaneous infusion does not require surgery, but it achieves something similar to what Duopa achieves. We have 2 options, and they're not approved yet, but I'm going to talk about them anyway because one of them may soon be approved and the other may follow within just a few years. The subcutaneous, by the way, means under the skin or into the skin. And the picture down here shows a so-called apomorphine pump. So this is a very small pump, can be worn on the belt, and it contains the syringe with the medication apomorphine. And apomorphine is a dopamine agonist that works very similarly to levodopa. The pump then infuses the medication through the tubing into this patch. And you might wonder how it then gets from the patch into the body. And the answer is that there's a small needle on the patch itself that hooks into the skin. So that's how it gets there. This is typically administered by constant infusion and can cut down off time and cut down dyskinesia. Apomorphine has been approved in Europe for, I think, the better part of 10 years. And rumor on the street has it that it will soon get approved in the US as well. Carbidopa-levodopa infusion is not yet available, but might be approved within the next few years. And this is a treatment that we've tested here at Barrow's. We also tested apomorphine, by the way, and both treatments seem to work really, really well. The downside is that when there is a break in the skin barrier, we run the risk of infection. So very, very good hand hygiene is needed in order to avoid skin infection and skin irritation. And yes, apomorphine may soon be FDA approved. I'm going to go back to the picture we talked about before with motor fluctuations and dyskinesias, and just show you the difference between taking levodopa by mouth and getting it as an infusion. Just like this person has fluctuating drug levels all throughout the day, which gets them into trouble, at least in the more advanced stages of Parkinson's disease. In this study over here, a similar person is taking levodopa, and the drug levels rise, as you see on the purple curve. They fall, they rise, and they fall, and they rise, etc. Compare that to a person who starts levodopa infusion. In the morning, perhaps at 8 o'clock, the pump is started. The drug level rises very slowly over about 2 hours. But then look what happens. The drug level stays exactly or almost exactly the same throughout the day. So this person on regular levodopa fluctuate up and down, and it's tough to get in the green zone and not have problems and just have benefit from the medication. But if you're on the pump, I'm sure you can see how it becomes much more easy to navigate this green zone and stay within the borders that either cause off time or cause dyskinesia. So I have high hopes for the infusional therapies, and I think most people who struggle with medication issues and who might be considering DBS might first want to consider one of these types of infusional therapies, especially the non-surgical ones. All right, moving on a little bit. Psychosis is relatively common in Parkinson's disease, but typically only in quite advanced stages. And it typically involves visual hallucinations, so seeing animals or children or people or shadows in the house or on the street or other places. It can be due to Parkinson's disease, but it's very important that we don't assume that that's always the case. It can be caused by multiple other things. Oftentimes, medications can be a trigger, either from Parkinson's or for another condition. An acute medical problem can place a lot of stress on the body and can trigger hallucinations. People who have onset of dementia might also be at higher risk of hallucinations, and so that's important to take into consideration when you're trying to address this particular problem. We have one medication that's been approved for treatment of hallucinations in Parkinson's disease, and that's Nuplazid. I actually find that a relatively good amount of people know about this medication because it is still heavily advertised on TV. But it has been around since 2016, and it, in my experience, works quite well to control hallucinations. The downside to it is that it takes anywhere from 4 to 6 weeks before it truly kicks in. So if someone is in a crisis and they're having a lot of issues, then I probably wouldn't reach first for Nuplazid, since it's not going to be immediate effect. There are alternatives to this medication, but these are all off-label. So quetiapine is probably the most commonly used. Clozapine is very seldom used, although it is very effective. And then rivastigmine is also used to some extent. All these medications, with the exception of rivastigmine, come with a black box warning. And I've pasted that here. It basically states that if you are older, if you have dementia, and if you have psychosis, then taking these medications come at an increased mortality risk. And that mortality risk is about 2 percentage points per 6 months. And I know that seems very dramatic, and it is, but we still do use these medications in carefully selected patients when the distress, when the problems from hallucinations are too severe. If someone has trouble distinguishing what is real and what is not, and if they are very distressed by hallucinations, then these medications are definitely indicated. Not everyone, by any stretch of the imagination, will have hallucinations or will even have severe hallucinations, and most will not require use of these medications. I'd like to highlight rivastigmine, even though it's an off-label treatment for this problem, because it is a medication without this black box warning that I find for most people is effective in controlling hallucinations. It is FDA approved for dementia and Parkinson's disease, and not FDA approved for psychosis. A lot of people with Parkinson's have, and we're covering a lot of ground today, are having issues with their blood pressure. When we stand up, gravity does its thing and pulls blood toward the feet, so that can cause a blood pressure drop, or it should cause a blood pressure drop, but our bodies adjust or accommodate to this change in posture and make sure that there's no decline in blood pressure. But this automatic control of blood pressure can sometimes be dysfunctional in Parkinson's disease. And so that may mean that a person with a blood pressure of 140 when they're sitting may have a blood pressure of 100 when they're standing. And that can cause lightheadedness and dizziness and headaches and pain and confusion, and it needs to be addressed. Oftentimes, medications might be the culprit. Sometimes it's the effects of blood pressure lowering medications. Other times it may indicate that someone is having an infection or another type of medical problem, perhaps a heart problem. And so the first order of business is always to figure out, is this Parkinson's related or not? If it does turn out that it's Parkinson's related and that the medications, and it's not caused by medications that the person is taking, then we might consider using a medication to raise blood pressure. Northera was most recently approved. Northera is the brand name for droxidopa, which basically works to increase the vascular tone and thereby raise blood pressure. There are other medications available, midodrine, fluorocortisone, etc., and some are not FDA approved. The main drawback to using medications to raise blood pressure is that you may fix blood pressure when someone is standing, but then when someone goes to bed at night, blood pressure may get really high, and we may actually run into the opposite problem. And for that reason, we recommend for most people to not take blood pressure augmenting or raising medications close to bedtime. Probably the treatment I get asked about the most is focused ultrasound. Focused ultrasound is a treatment that you see demonstrated on this picture here. It involves creating a small lesion inside the brain to control tremor on the other side of the body. So let's say someone has right hand tremor. Performing this treatment on the left side of the brain can control the right hand tremor. To do the treatment, you would need to shave the head, and then a frame with 1,000 ultrasound emitters is fitted to the head, and then the person is rolled into the MRI machine. The way it works is that the ultrasound emitters send ultrasound waves into the brain from pretty much any direction. And this doesn't cause any damage to the brain itself, but in the location where the waves meet, there is an increase in temperature, and that creates a small lesion, which then controls tremor on the other side of the body. Unlike DBS perhaps, as soon as you have the treatment, you have the full effect. So at least 50, 60, 70% reduction of tremor would be the expectation. But therein also lies part of the problem in that if you don't get the desired effect, you can't go back and redo it. It's already done. And if you have a side effect, such as tingling or slurred speech, or perhaps a little bit of worsening of balance, then you also cannot go back and redo it because it's done. And that's one advantage that deep brain stimulation has, that it is something that is adjustable and it's also on both sides, whereas focused ultrasound, as of yet, is only done on one side of the brain. Studies are ongoing to see if it's safe to do it on both sides. And studies are also ongoing to see if we can use it in a way such that we can control not only tremor, but also slowness and stiffness. And here I've outlined some of the pros and cons of focused ultrasound. And I think we covered most of these things. The very last thing I'm going to talk about is drooling. And the drooling is not caused by an excess production of saliva. It's merely caused by less frequent swallowing. So if saliva doesn't go down one way, it's going to come out the other way. And a lot of people will report first having perhaps some pooling of saliva in the mouth, then perhaps slight leakage at night through the corner of the mouth. And then during the daytime, they may actually have frank leaking of saliva out of the mouth during the daytime, and will have to perhaps walk around with a tissue or a handkerchief. So it can be a big problem for certain people. The way we inject either Botox or in this case Xeomin for this condition is by targeting the salivary gland on the side of the cheek called the parotid. And injecting that on both sides typically controls the problem really well for up to 3 to 4 months. In cases where injecting up here is insufficient, we may add the gland below the jawline called the submandibular gland. The only drawback to adding this gland is that you do run a slightly higher risk of causing swallowing problems, which is not a concern with the gland up here. Both Xeomin actually and MyoBlock were recently FDA approved for this indication. So I think that was kind of the main overview, and I hope it's been helpful, and I hope the slides are available and might be helpful to review as well. And I think it went a little bit over time, but I'm happy to take any questions that might have come in.
Thank you, Dr. Niemann. That was a wonderful overview of symptoms, treatments, past and present and future, which is really exciting to see some of the new possibilities out there. We have a few questions in our Q&A box. As a reminder to everyone, if you have questions, hover on the bottom of your screen, find that Q&A button and click on that and type in your question. We'll start at the top. Just what you were saying, Charlene is asking if we could get a copy of the slides.
Yes, I've shared with you a PDF, and feel free to share that with all the participants.
Great. We will send that out with our thank you emails at the end. If everybody would like that, just so you know, when you check your emails, it might go to spam with a group blast with an attachment. So check your spam folders too after this webinar is completed. Claire asked, is there a generic option for Rytary? If it's such a great drug, when can we expect a less expensive version?
Yeah, that's the million-dollar question, literally. There is no generic option, and I don't know when a generic option is going to come on the market. There are certain rules about when a medication can be made into a generic version, but unfortunately, the way the drug development market works these days is that whoever owns the medication may ask competitors to delay development of their own generic versions, and so for that reason, it's anyone's guess when this is going to become widely available as a generic, cheaper option. I would like to, though, add 2 points to what I mentioned in the talk. I think the main reason why this medication is so effective and why it should be used much more than it is not only because it cuts down off time and cuts down dyskinesia in many cases, but also because it provides a more steady, more natural level of levodopa. And there are studies that suggest that having a more steady medication level might reduce or delay onset of dyskinesia. And I think this is the reason why the infusional therapies with their very steady drug levels do just that: reduce off time, reduce dyskinesia.
Thank you. Not a question that's been posted, but my question, those infusional therapies, do you have a guesstimate on the price range for those in comparison to the Rytary?
Yeah, so the only medication that is currently available is Duopa, and it is very cheap with little to no copay. Since apomorphine has not yet been FDA approved, although it should be within the next couple of months, I don't know how much it's going to cost because the manufacturer simply hasn't released that information yet.
Great, thank you. Question from Eric. Would it be okay to take entacapone with Rytary?
Yeah, that's a great question. I wish I'd mentioned that in the overview. Yes, very much so. For most people, they may not need entacapone anymore when they take Rytary, but entacapone would give the Rytary an extra boost. And so certainly, yes, you can do that.
And Eric has another question. Can you take regular carbidopa-levodopa with Rytary? For example, take a regular carbidopa-levodopa just before exercising.
Yeah, so another great question. I'll incorporate that next time I give this lecture. Yeah, a lot of people do just that. Rytary is slower to kick in, and so if you are in a pinch and you need something extra, yes, you can take it before exercise. A few people that feel like it takes too long to kick in the morning, but then they're good the rest of the day, they actually take a fast-acting carbidopa-levodopa in the morning just to get going, and then they're fine. So yes.
Thank you. Another question about the PowerPoint. So yes, we will get that out within the next probably 24 hours. Bob is asking, his doctor is working on increasing his sleep, which has been very deficient. But now as his sleep is increasing, he's awakening with more tremors. Is there some treatment you would recommend considering for that?
Yeah, I think it depends a little bit on the specific details and circumstances. But when we sleep, we go through different phases. We have lighter sleep, deeper sleep, and lighter sleep, etc. When we get to the lighter stage of sleep, tremor may resurface, and typically tremor will be absent when we're in the deeper phases of sleep. So for the people that I see that have recurrence of tremor overnight that wake them up, I try to give them a bedtime dose of a long-acting version of carbidopa-levodopa, and that usually works pretty well.
Great. Molly with Senator Rosen's office is saying that if anybody would like to contact her with Senator Rosen's office, she is open to that. And I think you can see that on the Q&A. I will leave that there. Eric has another excellent question. Instead of Rytary, can you make a cocktail of fast-acting and extended release carbidopa-levodopa?
I would say yes and no. Mostly no, because extended release carbidopa-levodopa is not, in my opinion, a very good extended release medication. It's based on studies of how these medications are absorbed. Extended release carbidopa-levodopa, meaning not Rytary, is relatively unpredictable in terms of how fast the medication is being absorbed and how much medication is getting absorbed at any one time. So mostly I would say no. But with that said, there are a few people that I see where I've combined regular carbidopa-levodopa and carbidopa-levodopa extended release. And it seems to work okay in some cases, but typically not as well as Rytary. So it's not an equal substitute.
Thank you. Next question, and an anonymous attendee asking if an MRI would show Parkinson's progression.
No, there are certainly signs that one can see on an MRI that might be consistent with Parkinson's disease, but they require a very high, a very advanced type of MRI with a very strong magnet. And so on a regular MRI, these signs may not be apparent. And in fact, on a regular MRI of the brain, you wouldn't necessarily expect to see any changes. I always tell my patients that we're getting an MRI to look for other problems, strokes, tumors, or bleeds, or whatever the case may be. But I would expect your scan to be normal if there's nothing going on other than Parkinson's. But an MRI would not help you with determining progression.
Thank you. Bob asks, is there a solution to increasing time on during sleep so that sleep is not interrupted?
Yeah, I think it goes back to what I said before, that if someone is waking up because of they're off at night from tremor, difficulty turning over, stiffness, or cramps, then one option would certainly be to add a long-acting dose of levodopa at bedtime. But I also find that something like Nupro patch, which is a dopamine agonist that comes in a patch form and is exchanged once a day, can often have quite a big impact and cover you not just during the day, but also at night.
Exactly. Excellent. Sarah asks, is there any special training doctors need for Xeomin, since not all doctors offer Botox?
I would say there's training needed to be able to inject botulinum toxins effectively for drooling. But with that said, if a physician is comfortable using one type of botulinum toxin, whether that is Botox or Myoblock, then that person should be comfortable using all other types of toxins, since they basically work the same way, have the same time to kick in, have the same effect, and wear off after a similar time frame. The main difficulty is that the units of Botox might not be the same as the units of another type of botulinum toxin, so there is some conversion needed.
That makes sense. Claire is asking, does Medicare cover any of the medications or therapies, or is the copay for even Medicare still expensive?
Yeah, I feel Medicare covers most medications, but definitely have less coverage for the newer medications such as Rytary and some of the extenders. And the copays, even if it is covered, may sometimes be prohibitively high, and therefore effectively rendering them not covered. Depending on where your doctor works, what part of institution he or she is a part of, they may have internal support systems in place. In our example, we have the Ali Care program, which is a support program that helps patients get, as an example, reduction of their copays and help get them their medications covered. And there are other similar foundations that are accessible nationwide, such as the PAN Foundation. So I hope that answers the question.
That's great. Perhaps we need to see what's available locally here and make sure that we have that information on our website too for that. That's great. Charlene is asking, do you have any suggestions for people who have pain in the areas where the tremor is most significant? She has pain from knee to ankle where the tremor is constant.
Yeah. I see pain quite a bit, and I think it's relatively an under-recognized problem in Parkinson's. Um, I think it's important to try and figure out why is pain occurring. Is it because the limb is shaking and just the constant muscle activity back and forth causes muscle soreness and fatigue and pain, or is it because there is a cramp going on? Um, a lot of people with Parkinson's develop something called dystonia, and dystonia refers to an involuntary muscle contraction that leads to posturing. So that could be posturing of the neck to the side, or it could be curling of the toes and twisting of the ankle, and that can cause considerable pain. A thorough physical examination would help determine if that's the case. A thorough examination will also help determine whether is the pain caused by something else. Perhaps there is a problem with a joint or with a nerve, a pinched nerve that is then aggravated by the constant tremor. So I think I can't give you a specific answer for what to do in your situation, because it just depends on what the main issue is. But if it is driven by tremor, then the answer would be addressing that by increasing or changing the Parkinson's medications.
Yes, unfortunately, as we age and have tremors, sometimes it aggravates other arthritis and other problems too. Exactly. And our last question, unless somebody else speaks up, so to speak, Bob is asking your thoughts on photobiomodulation.
Yeah, I guess this is one where I'm gonna have to not give an answer because I simply don't know what that is.
That is fair. And we do have one last one from Eric. He's taking a 5200 extended release carbidopa levodopa at bedtime to try to keep dopamine levels. Would using one Rytary at bedtime be better?
Yes, I think so. It would be better by virtue of being longer acting. And the conversion in this case would probably be to 400 or even 500 or 600 milligrams of Rytary at bedtime. I think that would be more effective.
Okay, well, Bob is explaining the photobiomodulation as a red light and infrared light therapy on the brain.
Yeah, not something that I am aware has been tested in a major scientific study and shown to be effective. So I apologize, but I won't be able to give you a better answer than that.
Appreciate that. Okay, I believe that concludes our Q&A session. I was actually going to share my screen, unless did something else pop up then? Nope, we're good. Share my screen for some conclusion. First, I'd like to enormous thank you to Dr. Niemann for graciously donating his time and expertise to us. It's been a wonderful hour of lots of information, and we appreciate that we have the PDF of the slides to send out to everybody. And we will have the recording on as a link on our website in the next week or so. It takes a little bit of time for us to technically get that together. If you enjoyed this presentation, we encourage you to send us a note and we'll forward that on to Dr. Niemann as part of our appreciation. We would also like to thank all our members of the board. I don't know that I introduced myself before. I'm Dr. Mindy Lokshin, a former family physician currently chairing this group. Nicki Mueller has been unbelievable helpful in getting all the technological everything connected. And we have just a fabulous board of volunteers that step up and fill every need, which is wonderful. And thank you to everyone who has participated, sent questions, and we hope you have new insights into Parkinson's disease and the new treatment options. We would like to let you know some of the other things the Parkinson Support Center is working on. We are developing a mentor program. This is being developed in coordination with the Parkinson Association of San Diego. They have had a program going for a couple years, and so we don't have to reinvent the wheel. We are able to use their program. We are recruiting volunteer mentors, so people with Parkinson's disease, caregivers, or others simply with experience with Parkinson's who would like to help on a one-on-one basis people newly diagnosed or caregivers of people newly diagnosed. You would receive training from the Parkinson Association of San Diego. They have a very in-depth program. You are not expected to be an expert on Parkinson's, but simply help 1 to 2 mentees find resources in the area to help them live a better life. And you would have ongoing support from us with meetings and informational sessions, etc. We're also recruiting mentees for this, people newly diagnosed or caregivers, to be matched to one of these mentors to receive support and experience and advice on where to find help. We are starting up support groups. We know there are already several support groups in the area that are popular and doing well. We are offering training and support for the facilitators of these groups. We're hoping that there'll be maybe 2 or 3 facilitators per group. You are not to be an expert. You just handle the logistics of the meetings. We'll be offering training and monthly support sessions through the PMD Alliance, which is a national organization that has an experienced program to do this. Support group facilitators can be people with Parkinson's, caregivers, others, anyone interested in helping the community. So please let us know if you're interested. In the meantime, we are starting 2 groups. One will be a young onset Parkinson's disease group. It will be meeting in person. We haven't quite nailed down the location, but you will be getting information about that shortly. And a general Parkinson's disease group, which will most likely be in the northern Reno or Sparks area. And lastly, we have coming up a day at the Aces, the minor league baseball, April 24th, a Sunday at 1 in the afternoon. The Aces website isn't quite working yet for us to give the link for buying tickets, but tickets will be just $14. It'll be a great community event to meet everybody and just have a good time. We also were able to get Governor Sisolak to do an official proclamation for April to be Parkinson Awareness Month. So you can see we've been really busy. We're excited to have had our first webinar. We're excited to be starting our support groups and our mentor program. If you'd like to support us, please send us an email or go to our website where you will find our address to send a check, or like us on Facebook. So thank you everybody for participating today in our webinar, and particularly thank you, Dr. Niemann. We truly appreciate your time and your generosity with your expertise.
Thank you, this was fun.
Excellent. And if there are no other, I will stop sharing. If there are no other questions, I think we can. No other questions, we will close our meeting. Look for an email with possibly a brief survey on what you liked, didn't like, what you'd like next time, and the PDF of the slides. And we hope to see you all soon. Thank you.